Hello, bachcho. Dr. Omkar Sonawane here, your surgery faculty, and now we are here today basically to discuss about the surgery recalls in the recently conducted Fmge December 2025, which was conducted on 17th of Jan 2026. Now, first thing is about the preview of the examination, how that examination was. So, the reviews basically from the students, they say it was usually in the easy to moderate range, more on the moderate side, obviously, but some of them also found it difficult. Yes, because it is always a mixed bag of questions, as I've always told you. But one takeaway from this examination is that, especially surgery or the other clinical subjects, those who were there in the examination, they were not direct. The questions from these subjects were more conceptual, they were more integrated with other subjects, and the options were very much close or they were confusing at times. That's the reason. Two most important takeaways: one thing, that you have to make sure that you are studying the subject properly and thoroughly in a conceptual manner, okay, and in an integrated and a comprehensive manner. So that is one thing. Do not take shortcuts, as I've been always telling you. Taking shortcuts may help you solve few questions, but not all of them. And if you want a good strike rate in the examination and more confidence to face the examination, make sure that you do it from the main classes. Basically, that is what is advisable. One thing for all the upcoming FMG aspirants. Second important thing that you have to remember is, one, you have to solve more number of questions, because the more number of questions you will solve, the more better you will be with your integration, and secondly, you will be able to rule out the options very much easily. Okay? So those people who definitely took shortcuts, or those people who have definitely solved lesser number of MCQs, have found some things difficult in the examination. So that is the advice I would give you. All the upcoming FMG aspirants, make sure that these two advices are followed. Okay. Coming to surgery, basically, good thing was that majority surgery questions were from the predictable topics. And I've always told you, predictable ऐसा मतलब ये नहीं होता है that in each and every examination Glasgow coma scale and Q SOFA will always be there, right? Yes, those are more commonly repeated topics, but yes, there were commonly repeated topics, but there were few topics which were definitely the previous year ones, but the questions were more trickier, the options were more closer. That is the reason I say it's not important to solve only the previous year questions. More important is to understand that previous year topic, because any question related or near that topic, you should be able to solve that, right? It's not just you will rectify the answer for the previous year question and will be able to solve all the new questions. No, that does not happen. Clear? So make sure that this is followed. Let's start with the surgery recall. Okay, and this is moreover, I know definitely it is not going to be an accurate recall, because this time, one more thing that is there, a lot of long stem questions were there. Clinical case scenarios were almost 4 liners, 5 liners, and that was very common. The paper was much more lengthier as compared to the previous ones, and that's the reason people are not able to recall the exact language of the question. Even they're not able to recall the whole details which were there. But yes, as we always see, to pick up the keywords or the buzzwords of the question, people were able to pick up the keywords. They came to a provisional diagnosis, and based on that they have answered. So whatever I have discussed with students, whatever things students have informed me about the examination and the questions, based on that, basically we are trying to do this recall. It's not just for the purpose that you should be able to get your answers and all of that, right? No, it's moreover basically to understand which were the topics that are going to be asked in the examinations, or that have been asked in the examination recently, to understand that point. And second important, for those who are too much anxious and who those who cannot wait till the examination, for you to tell you, okay, these were the type of questions, and definitely this could be the probable answers based on the information that we have received from the students. Clear? And I have not spoken to one, but rather multiple students. Even if there are some problems, or there are some issues that you're having with these questions, please let me know in the chat box. Please let me know that what were the other options also, because I've not got all the options. So please tell me what were the other options in each and every question. With the question number, you can mention that in the chat box. And if you can definitely help me to make that question much more better with some additional information that you have got about the question, please let me know that also in the chat box. I'll make sure that I'll re-prepare this PDF again, okay, after the information that I've collected from you once more, and then I'll come up with the best possible or the nearest possible recall questions that would have been there. Clear? So as of now, let's discuss probable answers for all the questions. Now, one by one, let's start. The first one was a very easy, direct question. Everybody, as soon as they came out, they were happier. Okay, this question was there. So, as I always say, there are two, like one or two questions from swellings and one or two questions from ulcer. This time from ulcers, definitely I did not get any as such recall. But yes, there were two questions from swellings that came this time. So first was you are able to see a swelling in the floor of mouth, which and this swelling, as you are able to see, it was pushing the tongue on one of the sides. So they said it was not the actual image, but yes, the image was somewhere near to this. So there was a swelling in floor of mouth pushing the tongue towards one side. And this swelling, we know it happens due to collection of mucus, and this mucus extravasation cyst in the floor of mouth is nothing else but ranula, right? So do remember the answer to this question was ranula. So it was a spot diagnosis just by looking at image. The mucus extravasation cyst in floor of mouth is ranula, as we all know. That was the question. Okay. I hope they did not ask you about the treatment, right? This we have discussed even in the expected MCQs that I've conducted prior to the examination, the 3 videos which were there on my channel, and even in my main notes also you can find this topic. We have discussed that in swellings as well, right? So definitely we know that ranula is a mucus extravasation cyst which is transilluminant positive, and treatment is either marsupialization or surgical excision of the cyst as well as the sublingual gland, right? Next, question number 2, it was basically another swelling related question. There was some swelling given on the outer canthus or on the lateral canthus of eye. And we know, we have discussed it a lot of times. Any swelling on the outer or the lateral canthus of eye, basically I've told you sarkari bacha, right? That is a very classical case of nothing else but option A, dermoid cyst. And I know definitely the recall that I've got is they mentioned, sir, it was not only dermoid, they have written it as angular dermoid. So that's fine. Whether they wrote it as dermoid cyst or they gave an option as angular dermoid, it is one and the same thing. The answer has to be angular dermoid for this question. Please remember that. Okay, we know that sebaceous cyst has a punctum and a whitish discharge, and it is commonly seen in the scalp or scrotum. But dermoid cyst, on the other hand, it is not having any punctum, not having any discharge, and seen on the lateral or the outer canthus of eye. That is what is important. Treatment, we know it is surgical excision. Again, discussed in the expected MCQ session as well as in the notes as well. So we have discussed it multiple number of times, and I've told you this bacha has been repeated twice or thrice in the exam, right? Next important was question number 3, that says that what is the sign which can be seen in the below given image. I hope this was the easiest question that made you happier in the examination looking at this. This was the recent repeat from the previously conducted FMG on 26th of July, right? In the previous examination, what they did was they gave this intravenous urogram, and then they basically asked you what is the diagnosis. Now here on this time what they did was, instead of asking you the diagnosis, they have asked you what sign was visible. So we know here, if you see this intravenous urogram, you are able to see that the intramural portion of the ureter is dilated. And we know whenever this intramural portion of ureter is dilated, the diagnosis is a classical case of uretrocele, right? The diagnosis in this condition is classically uretrocele beta. And uretrocele is characterized by, all of you are quite aware, the classical adder head or the cobra head appearance. As I've always said, sarkari question. So this is one of those again. Adder head or the cobra head appearance or adder head or the cobra head sign was a classical feature of uretrocele, again discussed in the expected MCQ as well as in the main notes. Okay? So that is what is important. Chalo. And we know in cases of uretrocele, usually the treatment is a ureteric reimplantation that we need to do in majority of the cases. Okay. Next important, if I talk about question number 4, that was also a question basically from anesthesia and surgery, you can say, and this I've discussed in the expected MCQ1. The below given needle will be used for which type of anesthesia? I hope this was the framing of the question. Okay, so definitely here you are able to see this needle is actually having a beveled edge. We know beveled edge is also seen in varus needle, but please remember varus needle is not used for any kind of anesthesia. Varus needle is used for giving sorry, in pneumoperitoneum or for laparoscopic surgeries, right? So here definitely this was a needle which was used for anesthesia having beveled edge, and we have discussed it. I've told you this is a needle classically known as the Tovey's needle, and we know Tovey's needle is generally used for epidural anesthesia. So this is a classical picture of Tovey's needle, and the Tovey's needle which is there, it is classically used for nothing else but the epidural anesthesia. That is what is important to be remembered. Hopefully clear to all of you now. Chalo. Next is question number 5. Question number 5 says a patient presented after a road traffic accident with the below given injury. Okay, this was the type of injury, not exact image obviously. There was a image similar to this. In simple terms, what was the image? It was nothing else but a crush injury of the lower limb or a crush injury of the leg, right? So the image was basically of a crush injury of leg, and then they asked you according to the triage we are going to classify or you are going to categorize this injury in which category. So we know whenever there is a patient or whenever there is a mass casualty and when patients are brought to us, we have to categorize or we have to segregate the patients into various color coded categories based on the likelihood of survival and the severity of injury. That is classically known as triage. And according to triage, if they ask you that crush injury, okay, which happens usually due to building collapse and all, that crush injury is going to be classified into which category? So do remember, we know red category is for immediately life-threatening injuries. Beta, immediately life-threatening injuries means either if the patient is having cardiac tamponade, or the patient is having tension pneumothorax, or the patient is having tracheobronchial rupture, or if the patient sorry, or if the patient is suffering from a severe shock, any kind of shock, it can be severe hypovolemic shock, these kind of conditions, that is a red category beta, where patient needs an immediate intervention or an immediate resuscitation or a surgery as soon as possible. Okay? Whereas yellow category, it is for those patients who need a limb or a life-saving surgery beta, but they can wait for some time. Basically they're not going to immediately die, right? That is what is the yellow category patients. Okay, next is the green category, which is usually characterized by the minor injuries, ambulatory patients or the walking wounded patients, we know. And lastly, it is the black category, that is already the dead patients, moribund patients or the unsalvageable patients. Now if it is only a case of crush injury, then I would categorize into option B, that is yellow category beta. Okay, if it is only a crush injury, nothing else mentioned, to do remember degloving injuries or avulsion injuries. Okay, so any kind of, I've told you, any kind of fractures it may be. Okay, the compound fractures especially, any kind of compound fractures or any kind of degloving injuries or avulsion injuries, or basically a crush injury basically beta. Okay, but when the patient is stable, if they would have said that your patient is in shock, okay, if they would have said your patient is in shock, then you may have categorized into the red category. But if there was nothing about the hemodynamic status of the patient, they did not mention that the patient is suffering from shock, then definitely you should not classify it into the red category. Then you should classify it into the yellow category. If the hemodynamics were stable, only crush injury, yellow category. If the hemodynamics were compromised and the patient was hemodynamically unstable or the patient was in shock, then you can classify into red category. Hopefully clear. Now you are definitely knowing better. So depends on the hemodynamic status. As I've told you both the conditions. Okay? So whatever was given in the question, according to that, the answer would be decided. Hopefully clear. Chalo. Next is question number 6, Sarkari question again. So here they have said a patient is brought to you after a road traffic accident and he became unconscious after the accident and then again regained the consciousness. I hope all of you are quite aware that whenever a person after a head injury or head trauma becomes unconscious, then regains the consciousness and again becomes unconscious, we know it is a classical feature of lucid interval. It is classically known as the lucid interval, as we all are quite aware. And we all have been discussing so many times that lucid interval is a classical feature of which type of intracranial hemorrhage. So we know it is a classical feature of EDH or extradural hemorrhage. Secondly, you mentioned that even the NCCT was given or the finding was mentioned, and that is NCCT will show you definitely a biconvex or a, okay, it was showing you the biconvex or a lenticular hyperdensity. And we know if the NCCT head shows you the classical biconvex or the lenticular hyperdensity, basically, do remember it is a sure shot sign of EDH or an extradural hemorrhage beta. Okay, so lucid interval was mentioned, biconvex or lenticular hyperdensity was given. So we know the answer to this question is nothing else but EDH or extradural hemorrhage itself. Again, I've told you this question is a probable one, therefore discussed in the expected MCQ as well, right? I've mentioned lucid interval also and a biconvex or a lenticular hyperdensity as well. Whereas obviously in the main notes we have been discussing it quite like for a multiple number of times. I have told you this is a Sarkari question, always repeated either from radiology, surgery, medicine, forensic, somewhere or the other. Okay? Next is question number 7 now. They said a male patient was brought to you with complaints of scrotal swelling. Workup reveals that the AFP or the alpha fetoprotein is normal or negative, whatever was written, and LDH levels were elevated. People told me that definitely they mention about the LDH or the lactate dehydrogenase levels. I asked whether they mention about any placental alkaline phosphatase or SCG. They said no. So usually if they say, I've always told you one thing, that whenever there is a scrotal swelling or a testicular tumor, wherever the AFP is normal or AFP is negative, you can think about seminoma. Reason, the classical seminomas which are there, beta, those are AFP negative, right? In the main notes also, I've told you AFP is never raised in a case of seminoma. I've told you it gives you a cut potato appearance and large polygonal cells with prominent nuclei, giving you a fried egg like cells appearance which will be seen. Okay? Apart from that, even in the expected MCQ wala part also I discussed the same thing with you. Okay? So definitely here also I have told you the tumor markers for a seminoma are placental alkaline phosphatase, LDH and SCG. Okay? Same question has been discussed. So we know it is a classical case of nothing else but seminoma itself. Okay? We know the germ cell tumors were there in the option. People were saying, I have told you beta that germ cell tumor, whether it is a case of a testicular teratoma or a yolk sac tumor, these are going to be positive for the alpha fetoprotein. Okay? So if they say alpha fetoprotein is normal or it is negative, it cannot be a germ cell tumor like a yolk sac tumor or a teratoma. The answer has to be the most common testicular tumor we know, and that is seminoma. Hopefully clear to all of you. Next is question number 8. According to CAP classification, beta, they're asking you what is the stage of the given image. So here if you see the picture, here you are able to see some dilated veins, beta. And I've told you whenever the veins are dilated, but the dilatation of the vein, it is usually less than 1 millimeter. Such kind of veins we tend to call them as the telangiectasia or thread veins. These are classically referred to as the telangiectasia and or thread veins. So whenever the pooling of blood starts usually in these veins, they start getting dilated, and less than 1 mm dilatation is known as telangiectasia. And we have discussed the CAP classification for varicose veins, according to which C is for clinical manifestation, E for etiology, A for anatomy, and P for pathophysiology. So according to this, the clinical manifestation based classification we have discussed, and according to that, C1 is basically going to be your telangiectasia. The answer to this question has to be C1 stage. Do remember that. Even in the expected MCQs, I have discussed the same CAP classification. Okay? In that, I have told you about a PYQ, which was about lipodermatosclerosis. But here also I have told you that whenever there will be telangiectasias, okay, that is spider veins or thread veins, that is going to be the stage C1. Even in the main notes, we have been discussing it for quite a long time. There were two questions on varicose veins. The other we will discuss in a while. Okay, a lot of people are talking about the DVT question. So I hope there was no DVT question. They are confusing varicose veins and DVT together, I think. Okay, because no such DVT question has been informed to me as such. Okay, chalo. Next is question number 9, another question from trauma. They said a patient had a stab injury with some sharp weapon along with profuse bleeding or a continuous bleeding in the neck. Okay, and they even mentioned the zone of the neck injury, and that was between the cricoid cartilage to the angle of mandible. So in the main notes, I have been talking about the three zones of neck injury or the three zones of neck trauma, beta. I've told you for two types of trauma, they will only talk about zone of injury. One is the neck injury and second is the retroperitoneal injury. For this, they only say that in which zone the injury is there or what should be the treatment. So I've told you Zone 1 is from the suprasternal notch till the cricoid cartilage. Zone 2 is from the cricoid cartilage till the angle of mandible. And zone 3 is from angle of mandible till the base of skull. Right? So we know that the most common zone of injury is going to be the zone 2 itself, as we have been discussing it. Okay, so it is the most common zone of injury from cricoid cartilage till angle of mandible. And secondly, in zone 2, how the management of patients will be carried out. If my zone 2 patient will be hemodynamically stable, I should go for a conservative management or I should go for an observation that I've told you already. And if my patient is hemodynamically unstable, a zone 2 injury patient is hemodynamically unstable, okay, then in those conditions we should go for a surgical exploration. We have to explore the neck of the patient. So here they have talked about a zone 2 injury beta because they have said the injury is between cricoid cartilage to the angle of mandible. So we know it was a case of a zone 2 injury, and if it is a zone 2 injury we have to decide whether observation or surgical exploration. So here they also mention about a continuous bleeding. We know if they mention continuous bleeding, that means the patient would be hemodynamically unstable. And we know whenever the zone 2 injury patients are going to be hemodynamically unstable, in those conditions, we should directly go for surgical exploration of the patient, right? In those conditions, we should go for surgical exploration. If the patient was stable, then we might have gone for conservative management, but otherwise it has to be a surgical exploration. So that has to be kept in mind. Next is question number 10. Here we are having a question that is integrated with anatomy, ENT and surgery together. So here they have said a single patient or an elderly patient they mentioned who has undergone a thyroidectomy surgery, and a few days later they said she is not able to sing at higher pitch. And we have been discussing this question in surgery also and ENT also. So, this female, she is not able to sing at a higher pitch. Which among the following nerve is likely injured in this case? Okay? So, we know definitely that whenever the person is not able to sing at a higher pitch, that means the female or the patient is having a poor quality of voice, right? The patient is actually having a poor quality of voice. So after a thyroidectomy surgery, if the patient starts complaining of poor quality of voice, I hope all of you are quite aware that it is a classical case of nothing else but option A, that is a superior laryngeal nerve injury. Okay, a lot of people have asked that whether external laryngeal nerve was an option. They said no, that ELN or external laryngeal nerve was not an option. So if ELN is not an option, we know the ELN which is there, or the external laryngeal nerve which is there, basically it is a branch of superior laryngeal nerve. So if ELN was not an option, the answer has to be SLN, that is superior laryngeal nerve itself. Clear about? I've discussed this in expected MCQs. Similar question, exactly similar question I've discussed. I've told you that the patient has undergone a total thyroidectomy surgery. Okay, and definitely after that she is which is the most common nerve injured. I've told you at that time, if there is injury to the external laryngeal nerve, which is a branch of superior laryngeal nerve, that is injured, patient will definitely have a poor quality of voice. Okay, so this was discussed in main notes also. I've told you that external laryngeal nerve, if injured, there will be a cricothyroid muscle palsy, and as the tensor muscle is paralyzed, the patient has a poor quality of voice, so the patient cannot sing at a higher pitch, right? This has been discussed. So answer has to be external laryngeal nerve or superior laryngeal nerve, whatever was given in the option. Hopefully clear. Next is question number 11. If I talk about, it was a child has been brought to you after some foreign body ingestion. Okay, the child has been brought to you after a foreign body ingestion, and X-ray was given. They just asked you the site of foreign body. A question integrated with radiology and surgery. So you had to just see the location of foreign body. The easiest question. They did not even ask us about the treatment beta. So I hope all of you are quite aware. We have discussed this in the expected one as well, or in the main notes as well, as you are able to see in the picture. So here you can see beta foreign body ingestion that you are able to see. In this you can see that I've told you, whenever the foreign body appears slit like on the AP view and circular on the lateral view, that means the foreign body is located inside the trachea. But if the foreign body appears circular on the AP view and slit like on the lateral view, that means the foreign body is located in the esophagus. Here if you see the X-ray which was given, as people told me, was a X-ray AP view beta. So X-ray AP view was given, and X-ray AP view pe you are able to see a circular foreign body. And we all know that whenever the foreign body of the coin appears circular on the AP view, okay, that means the foreign body is located inside of the esophagus. The answer to this question was esophagus. So do remember that if the foreign body appears circular on EP view and slit like on lateral view, that means the foreign body is in the esophagus. So that was the answer for this question. Okay. Next important, if I talk about this question number 12, they said a surgeon was performing an endoscopy. Okay. Some people are saying You are inserting a nasogastric tube. Some people are saying endoscopy was given. Whatever it was, ultimately the answer would remain same. That will not change the answer. The surgeon was performing endoscopy and encounters an esophageal constriction that was 40 centimeters from the upper central incisors. Now they are asking what is the likely reason for this constriction over here. So I hope all of you are quite aware. I have discussed the same question in the expected MCQs also when I was talking about foreign body, and I've discussed it in main notes also during the esophageal anatomy. Now, important is we all know that there are four constrictions in the esophagus. At C6, we have the first constrictions, which is 15 centimeters from the upper central incisors, and that is due to the cricopharyngeal constriction or the cricopharyngeal sphincter. Second is 25 centimeters, which is at the level, 25 centimeters from the upper central incisors at the level of T4. That second constriction is due to the arc of aorta. Third is 27 to 28 centimeters from the upper central incisors at the level of T5, and that is due to the left main bronchus. I've told you this was a recent NEET PG question, and that's the reason I've told you it is expected to come. And this time there was a question that the constriction is 40 centimeters from the upper central incisors. That means at the level of T10, and we know it is basically due to the diaphragmatic constriction. Okay, the answer to this question is diaphragmatic opening. So, diaphragmatic opening or diaphragmatic constriction is 40 centimeters from the upper central incisors at the level of T10. That has to be remembered, beta. No issues with this, anybody? Clear? Chalo. Next important is question number 13 now. Another repeat, direct repeat from the previous 26 July FMG examination. Easy question, okay? And those questions are repeated. You usually remember that where a lot of people would have done a mistake. Okay? This was the question where a lot of people, a lot of students did a mistake in the last FMG examination. That's the reason. Definitely they have repeated this directly. Okay? So they have said that a patient is brought to you with complaints of a dilated tortuous vein on the medial aspect of the leg as shown in the image. Some people said that medial aspect of the leg was mentioned. Some people said it was not mentioned. Whatever it is, even if it is mentioned or not, image was clearly showing you that on the medial aspect of the leg you are having a dilated and a tortuous superficial vein. And we know this dilated or tortuous superficial vein on the medial aspect of the leg is always option B, that is the GSV or the great saphenous vein, right? It is always the GSV or the great saphenous vein, right? In the main notes also I have been talking about GSV, whereas in the expected MCQ I have almost given you a similar question. Okay, I've spoken about the nerve injury, as well as I've also told you that whenever they have mentioned medial aspect of the leg, beta, please think about the long saphenous vein or the great saphenous vein. Okay, so that is what is the thing that you need to remember. Next is question number 14. It states the given condition arises between which muscle fibers. Now, all of you are quite aware that the given condition which was there, it was nothing else but an esophageal outpouching, also called as a Zenker's diverticulum or the pharyngeal pouch. Now, I have asked a lot of people that was it a barium swallow given for the Zenker's diverticulum or the pharyngeal pouch? A lot of people said no, sir, it was definitely not a barium swallow. So, okay, beta, if it was not a barium swallow, some people were confused whether it was an X-ray, or some people were confused it was a MRI. Whatever it was, basically, if you were able to see outpouching from the posterior esophagus, beta, if you are able to see an outpouching from the posterior esophagus, so do remember it was a Zenker's diverticulum or the pharyngeal pouch. And we know Zenker's diverticulum or pharyngeal pouch, I have told you, it arises from the Killian's dehiscence. And Killian's dehiscence is that triangular space between which two muscle fibers. The answer has to be thyropharyngeus and cricopharyngeus. So it is a triangular space between the oblique thyropharyngeus and the circular cricopharyngeus muscle fibers. See, in the expected MCQs also we have discussed this, and even in the main notes. So, and I've told you this was a previous year question which was exactly and directly repeated in the examination. So never make mistakes in these kind of questions. Hopefully clear. Next is question number 15. If I talk about, it states that a child was brought to you with an anteromedial swelling in the inguinoscrotal region. What is the type of hernia? Now here a lot of people were confused and they have made a mistake, I feel. Okay. Now whatever was the information, you know it better, but still whatever information I could collect, it was basically a child that people are very sure about, which was given, and that child was having an anteromedial swelling, ठीक है, or a medial swelling in the inguinoscrotal region, and they were asking you the type of hernia. We know if there is a small child who is having a hernia or a swelling, so we know it is a case of a congenital hernia. and congenital hernia is the one which is usually present since birth. And it is a case of a congenital inguinal hernia because the swelling is in the inguinoscrotal region. Now, congenital hernia, if you ask me whether it is going to be direct or indirect, I would say basically we know that the most common type of hernia overall is indirect inguinal hernia, and most common type of congenital hernia will also be a indirect inguinal hernia. Why? Reason is beta, congenital hernia कैसे होता है? We know that we are going to have the deep inguinal ring and then the superficial inguinal ring. So from the deep inguinal ring, the processus vaginalis is basically going to enter inside the inguinal canal, and along with that, even the hernia sac can enter inside the inguinal canal. So we know that whenever a hernia sac enters via the deep inguinal ring, whenever the hernia sac enters via the deep inguinal ring, okay, and exits out via the superficial inguinal ring, we know it is going to be a case of nothing else but a indirect inguinal hernia. Okay, any hernia which enters from the deep inguinal ring and it exits out from the superficial inguinal ring, we know it is a case of an indirect inguinal hernia that had to be kept in mind. Clear? So that's the reason definitely answer to this question has to be indirect inguinal hernia. But again, I am giving benefit of doubt because definitely a lot of students were confused with that medial, whether it was only a medial swelling or they mentioned medial to inferior epigastric vessel. Because if this was mentioned that it is medial to the inferior epigastric vessel, then do remember the answer is going to change. Okay, as we have been discussing, if it is medial to the inferior epigastric vessel, then the answer becomes direct inguinal hernia beta, which is less common in children. We know it is more common in elderly patients as such. So, if medial to inferior epigastric artery or medial to inferior epigastric vessels was written, then the answer would definitely become direct inguinal hernia. But if that was not written, they only wrote a medial swelling, then the answer will remain indirect inguinal hernia. Hopefully clear. So depends on what was exactly written. Medial swelling, nothing else written, तो indirect बोलो. अगर medial to inferior epigastric vessel ये साफ साफ लिखा हुआ था, तो do remember it is direct. Next, question number 16. They said a patient had chest trauma with complaints of respiratory distress and X-ray has been given. Okay, what is the site for needle insertion during thoracocentesis or during the pleurocentesis? So we know definitely I've asked what kind of X-ray was given. So a lot of people were like, it was usually a X-ray of tension pneumothorax. So here you are able to see this kind of X-ray would have been given in the examination, where you are able to see there is hyperlucency or increased blackening on the affected side. There is going to be a shadow of a collapsed lung. Along with that, there was flattening of diaphragm, deep sulcus sign, and contralateral tracheal shift. These kind of features would have been there on the chest X-ray. And if this was the chest X-ray, we know it is surely a case of nothing else but tension pneumothorax. And we know as there is tension pneumothorax or air collected inside the pleural cavity, that is the reason why we had to perform a thoracocentesis. That is the reason why we had to perform a thoracocentesis beta. And if you want to perform a thoracocentesis, okay, in that condition, basically, what is the site for needle insertion or what is the site for needle decompression? So now the two closest option which people were confused with was option A saying second intercostal space on mid clavicular line, and option B is saying seventh intercostal space on mid axillary line. I've asked that was fifth intercostal space mentioned, so everybody gave me or told me that sir fourth or fifth intercostal space were not mentioned. ठीक है, तो याद रखना this was the similar question I've discussed in the expected MCQ or even in the regular like the main notes as well. So if I talk about basically this one, I've told you that needle decompression whenever we do, we have to do it in the fifth intercostal space anterior to the mid axillary line beta in adults, whereas second intercostal space on mid clavicular line in children. Okay, then I've also asked students that was any age group mentioned. So a lot of people told me that sir कोई age भी mention नहीं थी as such. ठीक है, so obviously if age was not mentioned, okay, and they have directly asked you the site for needle insertion for thoracocentesis or needle decompression in cases of tension pneumothorax, then consider that patient as a child and you can mark it as option A, that is second intercostal space on mid clavicular line. Because what is the best answer? It would be fifth intercostal space, okay, because majority patients would be adults. Considering that, we will mark it as fifth intercostal space. But if fifth intercostal space was not mentioned, then it may be a child because they did not mention the age. So let us consider that patient as a child, and then you can mark second intercostal space. One thing is that. Secondly, according to medicine or according to the previous edition of Harrison's, basically there was only second intercostal space on mid clavicular line as the answer for both adults as well as children. Okay, so we can consider that this question may be based on previous edition of Harrison. That is less likely though. Okay, but according to that, irrespective of the age, you had to mark it as second intercostal space on mid clavicular line. Though according to ATLS protocol now, I have told you adults के लिए fifth होता है, बच्चों के लिए second होता है. But if fifth was not there, basically you can go with second as the answer basically. Okay, so that is what is the thing you can mark here. Also, as I've told you, the same thing. Okay, chalo. Next is question number 17. A patient had severe respiratory distress after trauma and now airway has to be secured in emergency. The patient's airway needs to be secured in the emergency. So the incision will be made at which among the following site? An integrated question with anatomy and surgery. So basically they gave a picture of the anterior aspect of the larynx and the trachea, and they marked various structures as A, B, C, and D. They labeled them as A, B, C, D. And then they asked you that if you have to secure the airway in emergency. So we know whenever we have to secure an airway in emergency, we basically try for an endotracheal intubation, right? We usually try for an endotracheal intubation. I've told you that both in expected MCQ as well as in the main notes. Okay, but I've told you one thing, that whenever the endotracheal intubation fails, in those conditions, we have to go for a emergency cricothyroidotomy. Here also I've told you the same thing, that whenever the endotracheal intubation will fail, we have to go for an emergency cricothyroidotomy. So if you have to perform an emergency cricothyroidotomy, beta, we know that in this condition, the incision or the needle insertion has to be done in the cricothyroid membrane or the cricothyroid ligament. Now, if you see the structures over here, the A1 which is there, beta, it is basically marking or basically pointing at the it is basically marking at the thyroid membrane. So the A structure that you are able to see, it is nothing else but marking at thyroid membrane. Next, the B structure that is there, it is nothing else but the cricothyroid membrane. Okay, so the B structure that you are able to see, this one is actually your cricothyroid membrane. Okay, so this is your thyroid membrane, this is your cricothyroid membrane. The C structure is going to mark at the cricoid cartilage, and the D1, it was marking between the first and like between the cricoid cartilage and the first tracheal ring, beta. Okay, now important is if they ask you where you have to make an incision or a needle insertion, we know it is cricothyroid membrane, so it can be option B. Now again I'm saying here, obviously the labeling would have been somewhat different, but please remember whatever the labeling was, because some people are saying the A1 which was there, it was even above the hyoid bone. Okay, so now whatever was the labeling exactly, I'm not sure about what kind of labeling it was because nobody gave me the exact labeling, but yes, they all said yes sir, there was one point between the thyroid and the cricoid cartilage which was the cricothyroid membrane, and that was the site we have to make an incision for a cricothyroidotomy, that we all knew. So therefore I hope that all of you might have marked this answer right in the examination. To whatever, whether it was B or C, whatever was the labeling, that was the answer. But cricothyroid membrane had to be the answer. Hopefully clear? Chalo. Next is question number 18. Another question that I've been telling you. Okay? In ENT and surgery, I've told both of the cases. A person has suffered from burns, and along with that, there is signing of nasal hair. Signing of nasal hair is nothing else but burning of nasal hair. And I've always been telling you 5 signs. 1, if the person has any burns in the face or the neck region. 2nd, if there is signing or burning of nasal hairs. 3rd, if there is hoarseness of voice. 4th, if there are black carbon deposits or soot particles in sputum. And 5th, if the person is trapped in a closed burning room. In these 5 conditions, we know we have to always think about inhalational burns as the diagnosis. To all my students, they have told me easily, sir, there were signs like signing of hair or blistering of face or something. These kind of history was given, or these kind of features were given. So it was a classical diagnosis of inhalational burns. All of us knew that. And we know if it is a case of inhalational burns, we know the next step in management, if they ask you, does not matter whether they only say burns or they talk about inhalational burns. We know burns management may we have to follow the same resuscitation protocol as ATLS. So the resuscitation that we do in cases of burns, beta, it will be in the sequence that is similar to that of trauma, that is A, B, C, D, E, where utmost priority should be given for the breathing and the sorry, where utmost priority should be given for the airway and the breathing management, followed by that it has to be given for circulation. Does not matter whether your patient was hemodynamically stable, unstable, but if your patient is suffering from burns, and that too especially inhalational burns, I've told you in the main notes and the revision part as well, that whenever it is inhalational burns, airway management has to be the priority, or prophylactic intubation has to be the priority itself. Clear about? So a lot of people are not sure what was the exact option, but yes, whether it was airway management, or it was prophylactic intubation, or it was crucial management, some people are saying like crucial airway management or something like that. So whatever it was, airway management has to be the priority, intubation has to be the priority if the person is suffering from inhalational burns, or if you tend to follow the sequence of resuscitation as A, B, C, D, and E. Even in TND also, I've told you that you to tend to do this mistake. Just because they have said patient is hemodynamically unstable, BP 80/50, you immediately mark IV fluids as the answer. But I've told you, yes, we will talk about circulation, but after airway and breathing has been managed, right? Otherwise, the patient will die out of hypoxia. Clear? So that is the reason. Next is question number 19. Here we are having a female who presents to us with a complaint of a mobile breast mass measuring 4.5 centimeters in the right breast, and along with that, ipsilateral axillary lymph nodes are also enlarged, which are mobile. What is the stage of breast cancer? So this time they did not ask you the treatment, but they only asked you the stage of breast cancer. And it was not only the TNM classification, as we have discussed, they went a step further and they have asked you the stage of breast cancer. That too, they were not asking one or two, they went into more depth and they asked you 2A or 2B as well. Okay, so that was definitely somewhat more trickier and more in depth kind of a question. So that is the reason why I say you have to be basically more conceptually oriented for solving these kind of questions. So do remember that. We know that if the size of the breast mass is 4.5 centimeter, okay, according to the staging, it is going to be in the stage T2. Okay, if they say that the ipsilateral axillary lymph nodes are involved and the axillary lymph nodes are mobile, so we know it is going to be N1 whenever there is involvement of axillary lymph nodes and if they are mobile. They have not mentioned anything about distant metastasis, so we will consider it as M0. So the stage which was given was T2, N1 and M0. Now if you look at the further staging, so we have done, or we have said, stage 1 and stage 2, that is early invasive breast cancer mein we are going to have T1 or T2 with N0 or N1. Okay, so we knew that it was a case of a early invasive breast cancer, that is either stage 1 or stage 2. Obviously, so stage 3 was easily ruled out. It was not a stage 3 or a locally advanced breast cancer. Now important is, we knew that whenever there is involvement of the lymph node beta, okay, here you are able to see if it would have been, if it was a case of T2 along with N1, we knew it was a stage 2B. Okay, so please remember, if it is going to be T0 N1, it has to be stage 2A. If it is going to be T1 and N1, again it is going to be stage 2A. If it is going to be T2 and N0, then again it is a stage 2A. But whenever it is T2 with N1 or T3 with N0, I've told you it is going to be stage 2B. That is what is important to be remembered. I've told you this is an exception, right? T1 or T2 with N0 or N1, except T3, N0, M0. That was an exception which is included under the early invasive breast cancer or stage 2 beta. Hopefully clear to all of you. So definitely here the answer to this question was option C, that is stage 2B. Clear? So that is what is important. Next is question number 20. It's said, as I've told you, bile duct injury, favorite question, sarkari question. Okay, a surgeon was performing laparoscopy and a thickened gallbladder wall was noticed, and they said that the bile starts leaking out due to the injury to the common bile duct, due to a one-third injury to common bile duct or something like this was mentioned. So do remember, while performing laparoscopy, if you see a thickened gallbladder, and definitely they said for like if there would have been adhesions, and for due to that definitely the bile duct has been injured. Due to that bile duct injury, the bile might have started leaking out. Okay, if the bile has started leaking out due to the injury to the common bile duct, they have asked you what shall be the next best step, considering that the surgeon is inexperienced or untrained, okay, or the surgeon is having lack of skills. That was the question that they have mentioned. Now do remember here, I have told you in the main notes itself, we have discussed stepwise approach for bile duct injury even in TND and revision. Everywhere I've discussed this question time and over again because I knew this is one of the commonest questions repeated in the exam. Okay, so we know if there is a case of bile duct injury, this time normally they ask you what is done after the surgery, but this time they have asked you the question what is going to be done during the surgery if the bile duct is injured. We have discussed both. So whenever there is a bile duct injury which is identified during the surgery, beta, obviously if there is a partial injury to the bile duct, you should go for an immediate repair. But if there is a complete injury or a complete transaction of bile duct, then it depends. If there is no loss of segment as such, then okay, if there is just a complete transaction but there is no loss of segment, I have told you, you have to immediately go for an anastomosis over the T tube. You have to immediately go for an anastomosis over T tube, and this anastomosis over T tube can be done either by laparoscopy or it can be done by laparotomy, beta, whatever it is. If the surgeon is experienced or the surgeon has expertise, you can go for laparoscopy. If the surgeon is inexperienced or if the surgeon does not have expertise, then you can go for laparotomy or open surgery, right? That is what is important. Whereas if there was a complete transaction but there was loss of segment, that means if the bile duct is missing, a major part of the bile duct is missing, then anastomosis is not possible. In those conditions, you have to go for a Roux-en-Y surgery. That is either a Roux-en-Y choledochojejunostomy, that is connect the jejunum to the common bile duct, or a Roux-en-Y hepaticojejunostomy. Clear about? So that is what is done. But this is only done whenever the segment of bile duct is missing or there is loss of segment. Okay? So here they basically said that the surgeon is inexperienced or the surgeon is untrained. So obviously, doing any laparoscopic procedure is not going to be recommended then. So it's better to convert that laparoscopy into a laparotomy. Better go for a laparotomy and then do an anastomosis or a repair over the T tube. That has to be your answer for this question. So do remember that. Gallbladder bowel anastomosis was one of the options people said me. So no beta, gallbladder bowel anastomosis is not done. It is usually an anastomosis between the CBD or the hepatic duct and the bowel, not directly with the gallbladder as such though. Okay? That is one thing. And second, basically stop laparoscopy and closure. Again, that is not going to be option. One option was regarding ERCP. No. First thing is convert the laparoscopy into laparotomy and go for an open surgery and do a repair or an anastomosis over T tube. That has to be the answer. Question number 21. Another question was an elderly smoker patient presents to you with a history of cramping pain in the lower limb, and now there is a below given finding. People said that in the lower limb there was extreme severe kind of redness and some blackish or bluish appearance was also noticed in the tip of toes as well. What is the likely treatment? Sorry, not diagnosis. What should be the likely treatment of the case was the question. Now, we knew that whenever they talk about an elderly smoker patient along with intermittent claudication, rest pain, ulceration, or sorry, necrosis, it is a classical case of gradual arterial obstruction, and gradual arterial obstruction in an elderly smoker is more likely going to be a case of atherosclerosis. Okay, but here it was easier. Whether your diagnosis was right or wrong, the answer would be right. I hope so, because whether it is atherosclerosis or Burgess disease, beta, do remember one thing, that in both the condition, if there is necrosis, if there is a stage of gangrene, then we do not wait. I've told you that whenever there will be gangrene, you directly tend to go for amputation as the answer. Okay, so as there was gangrene over here, answer had to be option B, that is amputation to be done. Hopefully clear. Next is question number 22. Another direct question. I'm not sure whether there was any kind of history given because people gave me a direct question over here. That was, which is the most common vessel to bleed in peptic ulcer disease. So we know whether they say peptic ulcer disease, whether they say duodenal ulcer, whether they say ulcers on posterior wall, whatever they say, we know the commonest vessel to bleed in peptic ulcer disease, answer has to be gastroduodenal artery. That I've told you time and over again. Okay, everywhere we have been discussing this. In upper GI hemorrhage also we have discussed, and in peptic ulcer disease also we have discussed that the most common complication of peptic ulcer disease is bleeding. I've told you more common are going to be duodenal ulcers, and more common to bleed are also the duodenal ulcers. And the commonest vessel to bleed in duodenal ulcer is the gastroduodenal artery. That has to be the answer. So I hope all of you have marked this question right. Right? We know left gastric artery. I've told you left gastric artery मैं हमेशा बोलता था it is the commonest vessel to bleed in three condition. One is definitely the gastric ulcers. Second important is going to be the malarious tear, and third important is gastritis. In these three conditions, it is going to be the commonest one to bleed. Hopefully clear. Chalo. Next important, if I talk about this question number 23, beta, it states a patient is brought to the emergency with multiple episodes of vomiting. Along with that, there is severe chest pain and a subcutaneous emphysema. I hope there was macular stride like features which were given. I've told you macular stride means severe chest pain, vomiting, and subcutaneous emphysema. We have discussed that in the expected MCQ also, and we have discussed that in the main notes also. Okay. So we know that if there was features of macular striate given, it was a classical feature of nothing else but a spontaneous esophageal perforation, or that spontaneous esophageal perforation is known as Boerhaave syndrome. So the diagnosis in this condition was Boerhaave syndrome, and we know the spontaneous esophageal perforation of Boerhaave syndrome mein we have to go for the investigation of choices CCT, that is a contrast enhanced CT scan, where we tend to give a oral contrast, right? So I have told you here the investigation to be done is CCT scan. Okay, a contrast enhanced CT scan where you will give the contrast orally, so that from wherever the esophagus is perforated, from that part the contrast will start leaking out in the mediastinal cavity, and you can easily assess what is the site of perforation, what is the extent of perforation, everything properly. Clear? So therefore, upper GI endoscopy was one of the option that is not commonly done. The investigation of choice for Boerhaave syndrome is CCT scan. Hopefully clear. Chalo. Next is question number 24. It states a child was brought to you with history of multiple episodes of diarrhea, and now the child presents to you with rectal prolapse, or they would say a mass is coming out from the child's a mass is coming out from the child's anal canal, right? What is the likely management of the case? Now we knew it is a case of rectal prolapse, and rectal prolapse can be either a partial thickness rectal prolapse or a full thickness rectal prolapse. I've told you one of the important history or a risk factor that they will give for a rectal prolapse is nothing else but recurrent bouts of diarrhea. So they will say recurrent bouts of diarrhea, which makes the perineum lax, and due to that, there is an increased risk of rectal prolapse. So here, if they would have said a child, there was more risk of partial thickness rectal prolapse. If the patient was a child, there was a more chance of a partial thickness rectal prolapse in the baby beta. And we know whenever there is a partial thickness rectal prolapse in a child, if it is a very first episode, you should go for digital repositioning as the answer. If it is the very first episode of partial thickness rectal prolapse, the answer has to be digital repositioning. Just push back the rectum in its place. Okay, but if it is a recurrent case, then you have to go for a perineal surgery called as Thiersch wiring. But in question, a lot of people clearly told me, sir, it was definitely a child only, and there was a rectal prolapse. They did not mention any size or something. If they would have mentioned size, or if they would have mentioned about layers, then it may have been a case of full thickness. But usually if nothing was mentioned about the size or the layers basically, then please think about the partial thickness rectal prolapse. And if it is the very first episode of partial thickness rectal prolapse, we know answer has to be digital repositioning. Then the answer to that question has to be digital repositioning. If it was a recurrent case, if the patient has been brought to you twice or thrice, then you would have answer would have been Thiersch. But if it was the very first episode, go for digital repositioning as the answer. Hopefully clear to all of you now. Chalo, great. Next is question 25. Here they have asked you a patient was diagnosed with BPH, that is benign prostatic hyperplasia, and hence the patient was started on finasteride. They have asked you what is the mechanism of action of this drug. So I have basically told you this question beta even in the main notes and in the revision part as well. I have discussed about finasteride or BPH properly. So we know in benign prostatic hyperplasia we tend to give two drugs. One definitely we tend to give the tamsulosin, and we know tamsulosin is a selective alpha 1A blocker, and this tamsulosin or silodosin like drugs which are selective alpha 1A blockers, they basically tend to dilate the prostatic urethra, and as they dilate the prostatic urethra, they definitely increase the urine outflow of the patient. Okay, they tend to increase the urine outflow of the patient. That is what is about the tamsulosin or selective alpha 1A blockers. Okay, whereas if the patient is hypertensive also, then we give prazosin, which is alpha 1 blocker, a non-selective alpha 1 blocker. But we know along with tamsulosin or prazosin, we also give another drug that is finasteride. And we know that finasteride is a drug which is basically given to decrease the size of the prostate gland. We know the size of the prostate gland is enlarged. Therefore, to decrease the size of the prostate gland, we give a drug known as finasteride, which decreases the levels of active testosterone, or which decreases the levels of dihydrotestosterone by blocking or by inhibiting the enzyme which is responsible for activation of testosterone beta, and that is 5 alpha reductase. So we know answer has to be option C, that is inhibition of 5 alpha reductase. That is the mechanism of action of this drug known as finasteride. Hopefully clear to all of you now. So question from pharma and surgery both. Next, a question from PSM and surgery. This is rare, but yeah, this was a question which came. There was a question which said, question number 26. A patient was started on parenteral nutrition beta. Okay, parenteral nutrition, that is IV fluid. And we know the patient was started on parenteral nutrition, after which the below given TPN set or the below given total parenteral nutrition set will be discarded in which category of biomedical waste. So if you see, this is the TPN set which was given, and we know TPN set is usually made up of plastic, and all the recyclable waste like plastic and rubber has to be discarded in the red bag. So answer has to be option B, that is red. So do remember, any recyclable waste, that is whether it is plastics or it is rubber, that has to be discarded in the red bag itself. So do remember that point. Hopefully clear to all of you now. Okay, next is question number 27. It was a patient was brought to you with complaints of altered pancreatic enzymes, right? So patient, like, they did not mention whether they were elevated or something like that. Students told me, so they mentioned they were altered pancreatic enzymes. That means the serum lipase or serum amylase was altered, or the serum lipase and serum amylase levels would have been high. But some people also told me, sir, at the same time they also mentioned that the CA19-9, that is your tumor marker for pancreatic cancer, was normal, right? But they mentioned that a below given finding was there. That means there was some kind of a mass near the head of pancreas. Okay? Now, please remember, here there was some kind of a pancreatic mass inside the head of the pancreas, but they said there were altered pancreatic enzymes, but CA19-9 was absolutely normal. If CA19-9 would have been elevated, I would have considered it to be a case of definitely a pancreatic cancer, and then my answer would have been a Whipple's surgery. But here basically it is not a pancreatic cancer because CA19-9 is normal basically. So here it is not a case of pancreatic cancer, so Whipple's surgery is not going to be an option. ERCP and stenting was one of the options. I feel somebody told me ERCP and stenting or ERCP with sphincterotomy. But as the patient is not having any kind of jaundice, so definitely doing a ERCP and stenting or ERCP with sphincterotomy does not make any sense to me. Okay? So then it is more likely to be a case of a chronic pancreatitis where there can be some calcification in the head of pancreas. Either that could be a possibility, or it could be a case of an autoimmune pancreatitis where there is a sausage shaped pancreas. Okay, or it could be annular. Some people are saying annular, but problem is कि annular pancreas hota, so the patient would have bowel obstruction. Were there any features of bowel obstruction? Please comment down that below. If there were no features of bowel obstruction, annular pancreas is less likely as a cause then. Okay, so either it could be an autoimmune pancreatitis where there is a sausage shaped pancreas, or it could be more likely a case of a benign pancreatic tumors or pancreatic neoplasms like the sorry, mucinous neoplasms and all. Okay, so in those conditions, definitely initially we give a pancreatic enzyme supplementation, right? In those conditions, initially we tend to give a pancreatic enzyme supplementation itself. That's it. Okay, if it is causing jaundice, if it is causing any kind of other features, then I would have gone for definitely a surgery. Especially if the CA19-9 was high, I would have definitely gone for Whipple's. Okay. Question number 28. It states a child was brought to you with complaints of neck swelling as given below. What shall be the treatment? Now, please remember, there was definitely a child who was brought to you with similar kind of a neck swelling, which was usually seen in the posterolateral triangle of neck. Now, if the child is brought to you with a swelling in the posterolateral triangle of neck, we know it is a classical case of cystic hygroma, which is a case of lymphedema. Okay, it is a primary lymphedema known as cystic hygroma in the neck. Okay, here do remember that if it is a case of cystic hygroma, we know the treatment is surgical excision. But they went a step further and then they asked you that whether it should be a surgical excision done at birth immediately, or it should be a surgical excision at 1 year of age. These were the two options. So do remember, here it was more practical approach that you had to think about. Please remember beta that if the cystic hygroma was actually causing any kind of respiratory distress, okay, or airway obstruction, basically, if I say, if the cystic hygroma was causing any kind of respiratory distress, okay, in those conditions I should have gone for surgical excision immediately at birth. But if the cystic hygroma was asymptomatic, that means there were no pressure symptoms, neither there was any respiratory distress, nor there was any kind of dysphagia, nothing was there. If there was cystic hygroma which is only presenting to you with a swelling but no other symptoms, okay, no pressure symptoms, no respiratory distress, no dysphagia, then you can go for surgical excision at 1 year of age or 2 to 5 years of age, basically. That is what we recommend. ठीक है, so that is what is important. तो अगर कोई symptom नहीं था, then you could mark it at surgical excision at 1 year of age. If they mention about any kind of airway obstruction or pressure symptoms like respiratory distress or dysphagia, then immediately at birth has to be the answer. So it depends on what was the type of symptoms given or mentioned in the question. Next is question number 29. Here there's a female who presents to you with a complaint of breast lump which was diagnosed as a case of DCIS or ductal carcinoma in situ. We have discussed already beta that carcinoma in situ का मतलब होता है whenever the cancer only grows above the basement membrane. Whenever the cancer is only about the basement membrane, we call it as carcinoma in situ, has to be remembered. They said that an excision was done or a lumpectomy was done. We know for a case of a ductal carcinoma in situ, I have told you, for carcinomas in situ, the treatment is only removal of the lump, okay, with some normal margins, that is wide local excision or a lumpectomy. So we know the treatment for a case of a ductal carcinoma in situ is nothing else but a wide local excision, also called as a lumpectomy, that has to be done with some normal margins. And they mention there were around 2 millimeter clear margins. Some people are mentioning 2 millimeter, some people are mentioning 2 centimeter. Whatever it was, okay, there were normal margins or there were clear margins. That was the funda. Okay, whether it was 2 millimeter ka normal margins or 2 centimeters ka normal margins, basically, that was mentioned. Now, please remember, if it is a case of ductal carcinoma in situ, and secondly, if there are 2 millimeter or 2 centimeter ka normal margins, then why do we have to do anything after the surgery? मुझे बताओ. DCIS basically it is not going to be an invasive cancer, first thing. Second important, they did not even mention, you are saying about the high grade or low grade. Chalo, if they would have like if they wanted to go into much depth, they would have mentioned if it is a high grade or low grade, and tab jaake tension hota. But definitely here they did not mention whether it is high grade or low grade, nothing like that. And they have we even mentioned clear margins or normal margins. So if a surgery is done and you are able to get normal margins, why to do anything else after surgery? Nothing to be done. Just go for an observation. As I always say, under treatment is a problem, but over treatment is also a problem. Okay, so if you are getting clear margins or normal margins, do not go for anything after the surgery. That is what is important. So observation or follow up, whatever was there in the option, that had to be marked. Okay, now radiotherapy, a lot of people have marked it. So beta radiotherapy would be done in few conditions. First, if they would have mentioned if it is a case of a high grade DCIS or a high grade ductal carcinoma in situ, if they would have mentioned if it is a case of a high grade DCIS or high grade ductal carcinoma in situ, one thing. Second, it would have been the answer if they would have said that definitely you are not able to get like negative margins, the margins are positive, that means there are some malignant cells in the margins, so positive margins were there. And third important, which is a confusion, okay, which I was able to understand, and that was a case of recurrence. They said, sir, it was a case of recurrence. So they said that there was a previous ductal carcinoma in situ, basically, okay, for which a excision was done. Now there is a new lump, okay, and in this new lump again an excision was done and something like that. So in this condition you are able to get 2 millimeter clear margins or something. Okay, so this kind of a question was there. So if there was a case of recurrence, then you may go for a radiotherapy, but if there was no case of recurrence, do not go for a radiotherapy, better go for an observation only. That's it, nothing to be done more. Okay, next important is question number 30. A man presents to you with complaints of abdominal pain, fever, and weight loss, along with night sweats. So, people definitely mention that, sir, they have spoken something about the category B symptoms. Category B are TB like symptoms. We have been discussing it for a long time now. So, fever, weight loss, night sweats, these kind of symptoms they were mentioned as people told me. And they have said that below given radiographic image is given, what is the likely diagnosis? So, some people said it was a CT enteroclysis ka image which was given, and this was the classical picture that you are able to see. Matlab, if you see at the sides over here, you can see there is thickening of the wall. And I've told you, whenever there is thickening of the wall in the bowel, there is narrowing, and that narrowing is known as strictures. So यहाँ पे you are able to see beta, there are going to be strictures at the level of the bowel. There are going to be strictures at the level of the bowel which are going to be present over here. ठीक है? So whenever they say there are strictures at the level of the bowel, ठीक है? What is the likely possibility? Either the possibility is option A, that is abdominal cocks or ileocecal TB, or the Crohn's disease. Clear? In both the conditions, definitely the strictures are going to be seen. Okay? If definitely the features were similar to abdominal pain, fever, weight loss, night sweats, so we know that whenever constitutional symptoms of TB were mentioned, along with that, if you are able to see some kind of strictures, then I could think about intestinal tuberculosis or ileocecal tuberculosis or abdominal cocks as the diagnosis beta. तो अगर ये symptoms थे, then I would think about abdominal cocks. But if category B symptoms were not there, then I would more likely mark it as a case of Crohn's disease. The reason being, strictures are common in Crohn's disease too. String sign of Cantor we know, and Crohn's disease it is also seen. Okay, if constitutional symptoms of TB were not there, then my answer would have been definitely Crohn's disease itself. Okay, so that is important. So agar constitutional symptoms say, then my answer remains with intestinal TB, that is abdominal cocks. Hopefully clear. Next is question number 31, integrated question with derma and surgery. A patient who belongs to Tamil Nadu presents to you with the below given finding, and there was some black kind of granules discharging from the sinuses, but there was no bone involvement. This people told me specifically, sir, koi bone involvement nahi diya tha. So I'm like, fine. So do remember, if the person is from Tamil Nadu, that is especially from southern part of India, and there are black granules or the black sulfur granules discharging from these multiple sinuses that you are able to see on the leg beta. So we know it is a classical case of a fungal infection called as eumycetoma, also known as a Madura mycosis, right? So it is a classical diagnosis of eumycetoma or Madura mycosis. The Madura fort, Madura mycosis, all of this is same. We know the bacterial infection which was there, it would be called as an actinomycetoma. The bacterial infection is known as actinomycetoma, but in actinomycetoma, black color granules are not seen. In eumycetoma, the black granules are seen. So it is a case of fungal infection. So the two more options were of antibiotics. So as soon as we know black granules matlab fungal infection, so the antibiotic wala options would have been ruled out easily. You're left with two options. Either it was amputation and antifungals, or it was debridement and antifungals. Now, do remember, if they mention that no bone was involved, then you can just go for debridement along with antifungals. If they would have said that bone involvement is present, then I would have gone for amputation definitely. Then I would have gone for amputation. But if there is no bone involvement, if it is a superficial infection, amputation may not be required in all cases. There are some cases where debridement is going to be enough. Okay? Chalo. Next is question number 32. Another question which was a direct repeat from a previous NEET PG. Okay, a patient had the below given finding. What is the likely treatment? So in the main notes, I have been telling you quite a while that this is the picture that you are able to see. This is nothing else but a stone that you are able to see inside the floor of mouth, also called as a Sialolith. ठीक है, तो sialoliths are nothing else but it is stone formation inside the salivary gland. Okay, sialoliths are nothing else but stone formation in the salivary glands. Commonly, they are found inside the submandibular gland beta. That has to be kept in mind. Okay, the patient presents to you with a postprandial neck swelling. Okay, important is the investigation which can be done is the X-ray, and the X-ray in the floor of mouth. Okay, or the X-ray of the salivary glands is known as cialogram, and in that cialogram you are able to see a sorry, stone basically in that floor of mouth. Now basically they asked you that what should be the treatment. Now two or three options were there. Two options were having mandibulectomy in them. So obviously mandibulectomy is not required if it is just a case of a cialolith, or if it is just a case of a submandibular gland stone. So if it is just a case of cialolith beta, in those conditions you don't need any kind of mandibulectomy. So removal of mandible is obviously not required. Now either the question was removal of stone to be done or removal of submandibular gland to be done. If the stone was inside the gland, if the stone was basically inside the gland, then you may have to remove the whole gland or you have to excise the whole gland. But if the stone is inside the duct, if the stone is inside the duct, then we only have to do a removal of stone. Okay? And I feel that they have even mentioned the size of the stone also. Some people told me that, sir, it was around a 4 millimeter ka stone or something like that. So do remember, okay, if there is a 4 millimeter stone, basically, beta, okay, if there is a 4 millimeter ka stone, I've told you less than 4 to 5 ka stone can be easily removed by an endoscopy. So then in those conditions, removal of stone can be the answer. If it was a less than 4 millimeter ka stone, okay, which was usually found inside the submandibular duct, then the answer would be removal of stone only. But if it was a larger stone and if it was inside the gland, then the answer should be excision of the gland. Hopefully clear to all of you now. Clear? Next was a question which said a female presents to you with unilateral eczematous eruption of the nipple, and below given histopathology was noticed. Similar picture we have discussed in the main notes of surgery also. I've told you that you take a punch biopsy from the nipple areola complex, and in that you are able to see these kind of cells classically called as the Paget cells. Right? There are Paget cells in the epidermis. That is the thing that I've been telling you. Okay? We know that if there is a unilateral eczematous eruption or a unilateral eczema-like condition of the nipple, and there are Paget cells seen on the histopathology or Paget cells seen in the epidermis, we know this condition is nothing else but Paget's disease of nipple. This is a classical case of Paget's disease of nipple. And if it is a case of Paget's disease of nipple, I hope all of you are quite aware. Okay, people have told me, sir, they have asked you that which malignancy is associated with it. So do remember, I have told you always that Paget's disease of nipple is a marker of an underlying malignancy or a manifestation of an underlying malignancy. So this condition is going to be associated with which cancer? So this condition is associated with the ductal malignancies or the ductal cancers, like the invasive ductal carcinoma or ductal carcinoma in situ. But more commonly, it is invasive ductal carcinoma. So we know answer has to be invasive ductal carcinoma. So now some people are saying that diagnosis was asked. तो अगर diagnosis पूछा गया था, तो do remember the answer remains Paget's disease of nipple. If they asked you which malignancy is associated with it, then the answer becomes invasive ductal carcinoma. Beta. Hopefully clear to all of you. Now, yes, there would have been some more questions as well. Okay, I have not got the exact recall for all the questions, and even in these questions, if you are having some kind of inputs, just mention the question number and the inputs that are there in the question, or the options definitely that you are able to recall. Because sometimes, as I always say, even one word of the question, if it goes missing, the answer of the question changes. Or definitely, if the options are very close, then also depending on the answer, depending on the options, the answer may change as well, right? Depending on what kind of options were given. I always say that sometimes you do not get ideal answers in the examination. Both the answers are right, but which is more specific or which is more better, that you have to choose. So also try to recall the options if possible for you and mention them in the chat box. Okay, so that is one thing. Secondly, now the examination time is over, so do not have to overstress much. Okay, just it is the time for you to set sit back and relax, because you have been working really hard for the last 5 to 6 months. So now till the results, definitely do not keep on procrastinating, rather keep on enjoying now for some time. That is what I would recommend at this point. Okay, whatever the results are, whether they are in our favor or not, let let us discuss those results after they are out, not before that. Okay, so do not keep on predicting results, do not keep on thinking about what is going to happen and what not. Okay, at this point, this is the only time basically you are going to enjoy. Okay, even after the results are out and even when you pass, you will be stressed out about the passing certificate and about the internships. And even if you do not pass, then definitely that's a all journey together. But whatever happens, I've been always with you and I've always tell you that we are not going to leave your hand until you pass the examination. Okay, so I'm always there. Whatever problems you're having, you can reach out to me at any point of time on any of my handles, whether it is Instagram, Telegram, WhatsApp, whatever access you have, you can reach out to me. Bache. Clear? Chala. So take care and all the very best for your results. And I know most of you are going to come out with flying colors. Bache. Clear? Chala.